السلام عليكم. مساء الخير جميعا. It's nice to be here back to Kekish, my first home. In October 2015, I presented a grand round entitled Amblyopia, the Timeline. And that time it was the era of excitement about the binocular treatment of amblyopia, where the child can just watch video game and vision can improve. And I conclude with the slide, hoping that in the future, we will have the child sitting in front of a screen, watching a movie or playing his preferred video game, and we can treat amblyopia at the same time. So now, almost a decade later, time is flying. Is this hope still standing? What are the advances in amblyopia treatment? This will be the title of the grand round that presented today by Dr. Maan AlKharashi. Dr. Maan is Assistant Professor of Ophthalmology in the College of Medicine, King Saud University, and he is a full-time consultant in ophthalmology at King Saud University Medical City. He is also an instructor at the Department of Ophthalmology, Harvard Medical School in Boston, USA, and he's adjunct consultant at Boston Children's Hospital and Mass Eye and Ear in Boston. So welcome, Dr. Maan, to give your presentation. At the end, Dr. Huda Al-Ghadir will have some announcement to you.
السلام عليكم جميعا، حياكم الله. شكرا دكتور محمد على الانترودكشن. It's funny that 10 years has passed ومع الأسف أنا بنهي. I still hope that in the future إن شاء الله children will be able to sit and watch TV and have their vision improve. But this is the objectives of today's cycle. So first we're going to review amblyopia, the types of amblyopia. I know amblyopia is generally not the most exciting topic to be talking about in grand rounds. It's dull, but it's very, very important. As you know, it's the most common type of, or the most common cause of vision loss in children overall. And so we're going to discuss amblyopia. We're going to review the results of the amblyopia treatment studies. And this is the gold standard in the treatment of amblyopia. And we're going to shed some light on the latest advances in amblyopia treatment. Okay. So amblyopia, as you know, is a unilateral or bilateral, usually unilateral, cause of reduction in best corrected visual acuity. By definition, it's not directly caused by an organic defect in the eye or the posterior visual process. And as we said, it's the most common cause of vision loss in children. The prevalence is about 2 to 4% in North America. What makes it really important to talk about and always discuss is that it's a preventable and treatable disease if recognized early enough. Also, it's important to know that the reduction is in central visual acuity. The mechanism or the pathophysiology is not really understood, but there has been evidence of structural changes in the neurons in the primary visual cortex and the lateral geniculate body. Okay, so there are three main types of amblyopia. The most common type is strabismic amblyopia. Strabismic amblyopia, by definition, has to be unilateral because it's only in the deviated eye, not the fixing eye. And so, first, it has to be a constant deviation. Or if it's intermittent, then it has to be very poorly controlled. And there has to be constant fixation in one eye. So they cannot have alternate fixation because alternate fixation would reduce the chance of developing amblyopia. And so having said that, it usually happens in accommodative esotropia that's not treated or in partially accommodative esotropia. Can happen with intermittent exotropia only if it's really poorly controlled, and can happen with congenital esotropia, but that's usually not the case because they have alternate fixation. Usually the vision loss is gradual. And the second type is refractive. Refractive can be either anisometropic, when the difference in the refractive, when there is difference in the refractive error between the two eyes, or can be ametropic. Anisometropic is more common, and as you would expect, it's unilateral, so it happens in the eye with the worse refractive error. For amblyopia to develop in both eyes, you have to have severe refractive error. And so this table summarizes what we call an amblyogenic refractive error. Although this is really not set in stone, and so you can have many cases with either less refractive error with amblyopia or more refractive error without developing amblyopia. But as a guideline for hyperopia, children can tolerate hyperopia very well because, as you know, they have an excellent accommodation. And so up to 5 diopters of hyperopia should be fine in children. That's if it's in both eyes, of course. For myopia, it's also similar to 5 to 6 diopters of myopia should be tolerated without causing amblyopia, and that's because kids are usually more interested in things that are close to them. For astigmatism, it's a different story. So only 2 diopters of astigmatism or more should be enough to induce amblyopia in both eyes. And when we talk about anisometropia, of course, the numbers are a lot lower. So anisometropia of 1 or 2 diopters should be enough to cause amblyopia and hyperopia and astigmatism, 2 to 3 diopters in myopia. The third type is stimulus deviation. This happens when there is an organic cause for loss of vision. Anything that's blocking the visual axis, whether it's a cataract, vitreous hemorrhage, corneal opacity, ptosis. This can be unilateral or bilateral, depending on the cause. It's the least common cause of amblyopia, but it's the worst common. It's the worst type, and that's because there is no visual stimulation whatsoever. So it's the most severe type of amblyopia, like we said, because there is no visual stimulation to the brain whatsoever. And it has the narrowest critical period, meaning that it's the fastest to develop. Treatment for all types is the same. It's the same principle. So first, we have to eliminate anything that make the vision bad, correct any significant refractive error or misalignment of the eye, and then we force use of the weaker eye by either patching the other eye or using other methods that we will talk about later. So for deviation amblyopia, we have to eliminate any obstacles for vision. Most common type is congenital cataract, and so congenital cataract has to be treated very early on, especially if it's unilateral. In unilateral cases, we aim to do the surgery between 4 and 6 weeks of life. With bilateral cases, you have a little bit more room, so up to 2 months. It's also important that if you're not doing both eyes at the same time, to make sure that both eyes are treated within 1 or 2 weeks. And it's also very important that we correct the refractive error. So just doing the surgery is not enough. They have to be fixed with contact lens or glasses within 2 or 3 weeks from surgery. Now that's for congenital causes, whether it's cataract, ptosis, anything. For acquired causes, they can also develop amblyopia very, very quickly. Usually this depends on the age. Roughly we say 1 week per 1 year of life is the period to develop amblyopia. For example, if someone is 3 years old, developed vitreous hemorrhage, 3 weeks of that should be enough to develop amblyopia. And so they have to be treated very early on. After the treatment, then we correct any significant refractive error by glasses or contact lenses in cases of aphakia. A lot of kids develop sensory strabismus with the deviation type amblyopia, and most of them improve with treatment. However, if they not improve with patching, then surgery may be considered also. Okay, for strabismic, it's also the same. We correct any refractive error or misalignment of the eye. For cases of accommodative ET, as you know, just correction with glasses should be enough to correct the refractive error, and so we don't need to do any strabismus surgery. Classically, the old teaching used to be that we have to treat amblyopia before considering strabismus surgery. And more recently, it's been found that this is not necessarily true. So correcting strabismus early on with surgery can also be very beneficial for the treatment of amblyopia itself, because before with strabismus, the kid will not be using the amblyopic eye except when they are patching. But if you do strabismus surgery, have both eyes straight, then at least the kid will be able to use both eyes all the time, plus using the weaker eye only when they are patching. Also, doing strabismus early on has been found to help with the stereopsis. And so now it's recommended to do strabismus surgery. If there is still any amblyopia after, then it can be treated. For refractive amblyopia, same principle. Treat the refractive error with glasses. Now, when it comes to correction with glasses, for hyperopia, we usually don't tend to give the full correction. As you know, kids have very good accommodation, and so if the refractive error is amblyogenic, then we don't have to give the full cycloplegic refraction. We can reduce it by 1.5 or 2 diopters. And that's usually the case, except when there is strabismus. So if there is a component esotropia, especially if it's a cumulative esotropia, then they have to be treated with the full cycloplegic refraction because this will help with their strabismus in addition to helping them with vision. For myopia and astigmatism, we usually give the full correction. Okay, so this is a question for the residents mainly. So 3-year-old patient who failed vision screening with a visual acuity of 2100 in the right eye and in the left eye. This is their cycloplegic refraction. What would you give for correction? A, would you give the full cycloplegic refraction plus 2 plus 4? Or would you give plus 0.5 with plus 4? Or would you give plus 0.5 with plus 2.5? Or plain 1 plus 2.5? By raise of hand, who says A? I see 2 hands. B, C, and D. Good. So B is the correct answer. We always give full correction of the astigmatism. Hyperopia doesn't have to be corrected fully. Okay, we'll do another one. This is a 3-year-old who failed vision screening with visual acuity of 20/30 in both eyes. Cycloplegic refraction is plus 4 in both eyes. Would you A, give plus 4, or B, give plus 3, no glasses and follow up in 1 year, or no glasses and follow up in 6 months? Good. So most of you said say and D, and this is what we would do. In this case, the vision is excellent, so you don't have to correct, but plus 4 is a lot, so they are at risk of developing ET, and so I would prefer seeing them in 6 months just to make sure that they don't become amblyogenic or develop a cumulative ET. Okay, we'll keep this for the later. So then you have to force use of the amblyopic eye. This is usually and classically done by patching. You have all types of patches that can be used. There are all type of questions that can be asked, whether we have to do part-time patching, full-time, how many hours, what are the best type of patches. Also penalization, either by medications like atropine or optical by fogging the lenses, meaning that you give a refractive correction that is not the appropriate for the normal eye. And the new treatment modality, which is the binocular treatment, which we will talk about today too. Okay, so when do we stop patching? We stop patching if the treatment is successful, and we call the treatment successful when the vision between the two eyes is equal, or when at least the difference between them is 1 line only. Or if there is no improvement after 6 months of patching, and this is with good compliance and maximum amount of patching, which is 6 hours. So if you're patching a kid for 6 months with 6 hours of patching and they have good compliance with no improvement, then we say that they reach their plateau, and so we can stop treatment. Of course, the duration of patching depends on the severity, the age of patient, and the compliance. So someone who has poor compliance, patient who are older, and patient with more severe amblyopia will require longer duration period. Also, another thing to consider is that recurrence is very common. About a quarter of patients have recurrence after successful treatment of amblyopia. And so follow-up is very important after the treatment. Okay, whenever we talk about amblyopia, we have to discuss the pediatric eye disease investigator group. And this is a group of pediatric ophthalmologists, over 300 pediatric ophthalmologists in over 100 centers in the US, Canada, and Europe. Okay, so ATS1, this was covered over 10 publications and then over 15 publications after for the extended period of time. So ATS1 was to compare atropine versus part-time patching. And so this is, of course, all their studies are randomized clinical trials. And so this had 419 patients with moderate amblyopia. And so in ATS, they define moderate amblyopia as vision between 2040 to 2100. All the ATS studies included patients with either anisometropic, emmetropic, or strabismic amblyopia or combined mechanism, but they did not include the variation amblyopia. And so for ATS1, the patching group was 6 hours or more, and the atropine group was atropine 1% daily. The atropine patient or the atropine group had more acceptance for the treatment. Also, more patients in the atropine group had reduced visual acuity in the normal eye. However, that was only during the duration of the study, but on further follow-up, the vision was equal. And so the reduced vision is mainly because of the atropinization or the cycloplegia. If you look at the graph here, you can see that there was improvement. I lost the pointer. Here. So you can see that there was early improvement in the patching group early on. However, later at 6 months, the difference between the two groups was almost the same. So the treatment success was the same really between the two groups. At 2 years of follow-up, the visual improvement was also the same, so 3.7 lines in the patching group versus 3.6 lines. And so they concluded that atropine was similar to patching in terms of amblyopia treatment success. When they looked at the alignment and the effect of both treatment modalities on alignment, they found that patients who were orthotropic with no strabismus at enrollment, 18% of them in the patching group developed a new strabismus, and 16% of them in the atropine group developed strabismus. So there was no statistically significant difference. And that's the same for everyone. But it's interesting to know that patients who had microtropia, so a small amount of deviation, less than 8 prism diopters, 11 to 13% of them developed larger deviation, and 36% of them improved to orthotropia. Patients who had larger deviation at enrollment, 13 and 16% of them improved to orthotropia, and 32% improved to a microtropia, a small deviation. Okay, and so this is the same study, just with the extended follow-up, 10 years and 15 years, and it all showed the same thing, that atropine is similar to patching. ATS2 was to see the patching duration. How long do we have to patch? And for severe amblyopia, which is vision worse than 2100, they compared two modalities of patching. So patching for 6 hours versus patching full time. And visual acuity improvement was the same in both eyes, 4.8 lines in the 6 hours group and 4.7 in the full time patching. There was similar effect on ocular alignment. Adherence to patching, as you would expect, was better in the 6 hours group patient, so 53 versus 32 in the full-time patching. And also visual acuity was better in the normal eye in the 6-hour patching versus the full-time patching. And so from this study, now it became gold standard to just treat with 6 hours as treatment for severe amblyopia. For moderate amblyopia with vision between 2040 to less than 2100, they compared 2 hours of patching versus 6 hours of patching. And the same thing, the results were really similar. And so if you look at the graph, you'll see that the numbers are almost identical. There was also similar adverse effects between the two groups. And of course, 6 hours of patching was not as accepted by patients and parents. This study was to look at the amblyopia recurrence rate. And so all patients who received treatment for amblyopia were followed for 1 year after discontinuing the treatment. And they found that 24% of patients had recurrence. The recurrence rate was the same whether they were treated with patching or with atropine, so 25% in the patching group and 21% in the atropine group. This point is really important. So tapering the hours of patching reduced recurrence rate. Patients who were patching 6 hours and then stopped immediately, they developed recurrence in 42%, versus patients who had a tapering patching developed recurrence in only 14%. Okay, ATS3 was to look at amblyopia treatment in older kids. And so they studied all kids with moderate or severe amblyopia, so vision 2440 to 2400. The treatment duration was for 6 months, and the treatment was group A, glasses with patching or atropine. Group B, the control group, was glasses alone. And so this is really not a control group, because if they are receiving glasses, then they are also being treated for amblyopia. So it's really a comparison between two treatment groups, whether it's glasses alone or glasses with patching. And so kids who improved by 2 lines or more, the younger kids, as you would expect, between 7 and 12, they had better response. So 53% of the treatment group who were having glasses and patching improved versus 25% in the glasses only group. And this was statistically significant. When you look at older kids who are 13 to 18 years of age, the difference was not significant. Only 25 and 23 improved. However, when you look at older kids who never had treatment for amblyopia before, then you have a significant difference between the two eyes. Yeah, so 47% and 20%. ATS4 was to compare daily atropine versus weakened atropine. This is for cases of moderate amblyopia, 168 patients, and the results are the same in both groups. So both groups had similar results. And so there was also similar adverse effects in terms of visual acuity in the normal eye or ocular alignment. This point is interesting. So the group who had weakened atropine was also associated with more concerns with compliance. So there was poor compliance in patients who had only the weakened atropine versus the daily atropine. And this is probably just because of when you do it daily, then it becomes a habit, and so it's easier to do versus when you have to remember to take it on Saturdays and Fridays. However, after this study, most people would do only weekend atropine instead of daily atropine because there is still the systemic side effects of atropine. ATS5 was to see the effect of wearing glasses alone without patching, and so they looked at patients who were only treated with glasses. Visual acuity was between 2040 to 2250. There was no limitation of the follow-up period, but they had visit every 5 weeks. And as you would expect, 77% had improvement of more than 2 lines, and the amblyopia was resolved completely in about 30% of patients. And of course, the response will be better if the visual acuity to start with was not severely affected and the difference between the two eyes was not severe. And then those patients who had treatment with glasses were then randomized into 2 groups, whether they can continue wearing the glasses alone or add patching. And so they do 16 weeks, 4 months of treatment with glasses, and then get randomized to either adding patching or continuing glasses alone. And as you would expect, the difference was significant with patching group, so they improved by 2.2 lines versus 1.3. Initially, at 5 weeks, there was no significant difference. Okay, ATS6 looked at the near versus distance activity while patching. So there used to be a thought that if you do near activities while patching, then vision will improve faster. And so this study was to prove or disprove this theory. And the visual acuity improvement was actually the same whether the patient is doing near work activity or distant activity. Um, and so it doesn't really matter if the kid is doing near activities or distance activity as long as they are patching. This is a 6-year-old patient. The mother is noticing some eye crossing when the patient is tired. Visual acuity is 20/20 in each eye. Cycloplegic refraction is +5 in both eyes. He have ET of 16 and 20 present diopter intermittent. A, give +5. B, +3.5. No glasses since the vision is excellent. ممتاز. هذا أهم شيء إن ما حد يقول no glasses. Because there is intermittent exotropia, and so it's better to treat, especially if there is poor control. Now, whether to give the full correction or not, you can argue both ways, but with this excellent vision, you can start with the lower prescription and then follow up later. Okay, ATS8 was to compare atropine alone versus atropine with glasses, and this is for patients with moderate amblyopia. Sorry, this is to compare atropine with atropine versus optical penalization. And so the second group had atropine and were given a plano lens in the normal eye. Improvement in vision was similar between the two groups. There was actually better improvement in the atropine with plano lens, but the difference was not statistically significant. But what's really important is this. At 18 weeks, there was reduction in vision in the normal eye in the group who had atropine and optical penalization. Most of these differences did not persist, but some did. And so it's better to just treat with atropine without optical penalization of the other eye. Now, in older kids, can you treat with atropine also? This study was for patients with moderate amblyopia. They were treated with weekend atropine versus 2 hours of patching. The atropine group did a little bit less, but statistically there was no difference between the two groups. And so both treatment modalities work for patients with moderate amblyopia, even if they are older. The amblyopic eye visual acuity was 20/25 or better in 17% in the atropine group and 24% in the patching group. So the patching group did a little bit better, but statistically there was no difference. ATS10 was to study the effect of patching versus wearing Bangerter filters full time. And so those are filters that go on top of the glasses that makes the vision a little bit blur. And there are different grades that can be used depending on the severity of amblyopia. So this study was for patients with moderate amblyopia. Both treatment modalities work. Wearing the Bangerter filter was easier for patients because they just wear their glasses without patching. In terms of side effects, it was the same in terms of stereopsis or development of strabismus. Compliance was better with the Bangerter filter, so 88% of patients had no problem wearing the filter. Now, patients who have residual amblyopia, so patients who had the treatment for amblyopia but did not improve, can they be helped by adding atropine to patching? So they compared a group who had patching only, continued patching, and the second group had patching and atropine was added. The difference was not statistically significant. In fact, the group who had patching alone did a little bit better, but there was no statistically significant difference. Also, the study was stopped early because it was clear that there was no significant improvement. Vision therapy was also another study that had to be stopped because uh, there was no improvement with vision therapy for amblyopia. So vision therapy doesn't really help. Levodopa, this is an interesting study. Levodopa is a medication that gets converted to dopamine in the body, and dopamine has been found to play a role in the retinal function and the central visual processing. And so the idea was whether doing levodopa will help with improvement of amblyopia. They started with a pilot study. Results were encouraging, and so they did a clinical trial for patients with moderate to severe amblyopia, uh, aged between 7 to 12. So they studied older patients. And the randomization was either to do patching for 2 hours in addition to levodopa or doing patching with a placebo. The difference between the two groups was not statistically significant. So you're talking about 1.4 letter between the two eyes, which is really not significant. However, there was no serious adverse effect from doing levodopa, but uh, after this study, no one really became interested in the idea of using dopamine for treatment of amblyopia. Now, patients who had residual amblyopia, we already know that adding atropine does not help, but how about increasing the amount of patching? So those are patients who has been treated for amblyopia for at least three months before the treatment. And then we're randomized to whether to continue patching the same for 2 hours or to increase to 6 hours of patching. And as you would expect, they found that the group who had 6 hours of patching did improve more, and the difference was statistically significant. And so now it's recommended before stopping amblyopia treatment and declare plateau of vision to increase the amount of patching to maximum, give it 6 months, and then if there is no improvement, you can stop. Okay, so to summarize all what we talked about, for moderate amblyopia, where the vision is between 24 to 40 to 2100, atropine is the same as patching. Also for older kids, it's the same. Whether to do 2 hours of patching or 6 hours, there was no difference. And so most people now for moderate amblyopia will do 2 hours only. Do you have to take atropine every day or on the weekend? There was also no difference. And so most people now will just do weekend atropine. Although compliance was a little bit less with weekend atropine, but it's still better than doing it daily. Patching with glasses is obviously better than doing glasses alone. However, we know that wearing glasses alone improve vision in 77% of patients, resolve amblyopia completely in about 30% of patients. And so it's always recommended to uh, wear the glasses for 4 or 6 months before starting amblyopia, except when the amblyopia is very severe or the patient is older, and so you don't want to waste time. Bangerter filters are great. I never use them, but they work just the same as patching. For severe amblyopia, 6 hours of patching is equal to full-time patching, and so no one does full-time patching now. Patching with glasses is obviously better than doing glasses alone. For residual amblyopia, levodopa is really not that interesting. Increasing the patch to 6 hours is always recommended before deciding to stop the treatment. Okay, another point to consider is that amblyopia recurrence is very common. 25% have recurrence, and so it's important to continue follow-up after successful amblyopia treatment, and important to taper the patching instead of stopping it cold turkey. Amblyopia can be treated in older kids between 7 and 18, especially if they never had any amblyopia treatment before. Anisometropic and strabismic amblyopia can be treated with glasses alone, like we said, especially if their vision was good to start with and the difference between the two eyes was smaller. And performing near activities really does not add much to the treatment. And so it's fine to do whatever they want as long as they are patching. Now we'll talk about what they call the digital therapeutics or the binocular treatment. And this is a new modality of treating amblyopia. The thought is one, it's less boring, and so hopefully kids will be able to do it more. And two, both eyes are being stimulated at the same time. And so it was thought that this may help with stereopsis development instead of patching. And so most of these treatment modalities are based on the idea that different pictures are presented to each eye by using those dioptic glasses. So you have a red and green filter, and the game or whatever content they are watching is presented with red and green. So each part will be presented to one eye alone. And so in the sound eye, if the normal eye was, for example, the eye that's wearing the blue lens, they can reduce the contrast. And so usually we start with 15% of contrast in the normal eye, and this will stimulate the weaker eye to work more while the patient is wearing their glasses. And so ATS 18 was to study the effect of this dioptic treatment using the Tetris game. This was for kids with moderate amount of amblyopia. They enrolled 385 patients, and they had 4 months of treatment with either the binocular iPad game for 1 hour per day or patching for 2 hours a day. Results are not that exciting. The difference between the two groups was similar. In fact, the patching group did a little bit better. Um, the difference was not significant. However, this exceeded what they classified or defined as non-inferiority. So this study was to see whether the binocular treatment is inferior to patching or not. And the difference exceeded that definition. And so they proved that the binocular treatment was in fact a little bit inferior to patching. And this is really important. So only 22% of kids in the binocular group uh, completed the 75% recommended type of treatment. And so compliance was really bad with the binocular group. And they recognized that Tetris is not that exciting for kids. And so they moved to ATS 20, which is the same idea. However, they are using a more exciting game, Dig Rush Rain. It's the same thing. So we have a miner that goes and collect gold, put it in the cart and push it back. The pictures are presented differently in each eye, and so they want the kid to play for 1 hour, only 5 days a week instead of every day. And they are comparing it to glasses only. And so for the older cohort, patients who are 17 to 12 years of age, with either an isometropic, strabismic, or both mechanisms, were enrolled in the study. So at 4 weeks, the group who actually did glasses alone without playing the game did a little bit better. At 8 weeks, the results were the same. And so doing the binocular treatment was not found to be effective, uh, especially given that this group is wearing glasses alone, so they're not doing patching. There was no improvement with stereopsis. Compliance was a little bit better with this game, so 78% completed 75% of the prescribed amount. However, when looking at the device itself, about 58% only of the group completed the treatment. In terms of side effect, there was no significant side effects recorded, whether developing of strabismus, developing headaches, or anything else. It was the same in both eyes. Points to consider in this study is that they looked at patients who are slightly older, so we know that the response to treatment will be less. And 96% of these patients had already been treated for amblyopia before. And so it's expected that they won't improve with further treatment. Different studies outside of the PD group also looked at the same game, and they had mixed results. So some studies showed significant improvement with the game. Some studies showed that there was no difference. When they looked at the same game but doing it in a younger cohort between 4 to less than 7 years of age, the results were also the same. So they compared binocular treatment with glasses alone. The binocular treatment did a little bit better, but this difference was not significant. Also, compliance was not great, so only 47% of kids did the 75% of the prescribed treatment or more. Now, this device is a little bit more interesting. So it uses the same principle of doing the dichoptic treatment. Um, However, what makes this interesting is that the content is different. So instead of playing a boring game, they can watch a movie or a TV show from a licensed provider. So they have Disney, Netflix, Nickelodeon, stuff like that. And so the kid can choose whatever they want to watch. And so the hope is that kids will be more compliant with this treatment. It's the similar idea using dichoptic treatment with reduced contrast in the normal eye. However, instead of using glasses and an iPad, they use this virtual reality headset. And so there has been two studies, one comparing the binocular treatment with glasses alone, and there was significant difference. So the group who had the binocular treatment had more improvement. Also, compliance was excellent. So 88.2% of patients completed the treatment. There was no significant side effects. Some side effects of reported headaches, but nothing too serious. CureSight is another device that uses similar principle. However, instead of using a virtual reality headset, they have an iPad with glasses. What makes this more interesting is that it has an eye tracker, so it can track where the patient is looking, and it can mask part of the material for the normal eye. So it uses the same dichoptic principle in addition to masking some of the areas in the normal eye, in addition to producing lower contrast in the normal eye. And so they compared using the device for an hour and a half a day, 5 days a week, compared to patching 2 hours, 7 days a week. Also, with this device, they can stream anything from the internet. So this makes it really good in terms of compliance. They can watch whatever they want. There was a statistically significant difference between the two groups. So the kids who did the binocular treatment did better than doing patching. Also, as you would expect, compliance was excellent with this treatment modality. So 91% did adhere to the treatment. No significant side effects also. So future is still promising, like Dr. Muhammad said, but most of these things are still not available. I mean, CureSight is still not available and you cannot prescribe it. Luminopia is available, can be prescribed in the US. I've never seen it here in the region, and so I don't think they started their business here.